I came to St. Francis in 1987. When I came home to my wife when I took the job, I said, I think I have the job. She goes, what do you mean you think you have the job? I go, they're not exactly clear about things, but they told me my on-call schedule, which was really easy. So she goes, oh great, what's your on-call schedule? I tell her, I'm on for the first 5 years. So literally for the first 5 years, these guys didn't carry beepers. They're great docs, I love them, but for 5 years, they gave me the opportunity to build my practice. And the first weekend, I was fresh out of fellowship, and my partners both went on vacation the first day. They handed me the keys and they said, welcome. We don't do that anymore. Now, if we have a new partner, we're with them for the first year when they're doing procedures, and it was a different time back there. And this first day was a July 4th weekend. I don't know the hospital, I don't know anything here, and everybody's gone, and everyone signs out to me. I'm alone in this hospital. And I had multiple acute heart attacks coming in, myocardial infarctions. And one was on a Saturday night. It was a 40-year-old woman, I'll never forget it, and she dies on my table. And it's like a nightmare that you live afterwards, and I remember I was sitting there crying in my office, just thinking about it, saying, I can't do this. This is insane. But, you persevere and you have tons of triumphs, but occasionally you don't. And that very first weekend was words can't describe it. You got to get back in the saddle and take care of someone again because someone else needs you. But I'll never forget that weekend. It was something we lived with.
So what did you bring? I mean, you have a lot of nice ingredients. It's so colorful.
Yeah, so that's the key thing, colorful. Everything is about color.
Wow, that's great. I love it.
And then you just toss this, and you have your lunch.
You're a guy who's been there how many years?
My 34th year.
34th year. Caseload a year, generally speaking?
Over 3,000.
3,000 a year. And by the way, everybody who goes, they get your cell phone number, right?
Yeah.
And it's not like you have 50 cell phones. You have one cell phone.
Just one. Dr. Shlofmitz. I grew up in East New York, Brooklyn, low-income projects. I had really simple parents. They were, immigrants, really good, hardworking. They never let us know how poor we were. We didn't know. And they taught me how to treat people. And you treat people the way you want to be treated yourself. It's patient care. There's a picture up there that one of my partners got me. It's a picture of a doctor in a field. And I always tell people, they say, oh, you're an interventional cardiologist, you're head of cardiology. I go, I'm a family doctor. My patients call me for anything, whether they have a cold or their internist is on vacation, they need a prescription, because at the end of the day, we're doctors first. If I went into medicine, to me, it was a privilege to be a doctor. So instant access is the key for a patient relationship to me. Whether I'm on vacation or away 24 hours a day, my patients can get me.
Okay, I'm sorry to bother you. And when she came over, they're mildly swollen.
Okay, well, you're not bothering me.
They're not, whatever. She had no...
You're fine.
I might have stepped on the feet or had a splinter from my deck.
Doctor, I'm comfortable with you and you've seen it all. I had no bra on. I woke up and I'm big and floppy. I'm 80 years old now, okay?
You didn't trip or anything, did you?
God bless you. I love you.
And the thing is, there's good and bad. I mean, nobody's perfect, and I am far from perfect. So my patients know they can reach me, and that's tremendous advantage. Someone needs a prescription renewed. Saturday night at 10 o'clock, they forgot their meds and need to be renewed. Well, really? You're waiting till Saturday night?
For what am I getting? Okay.
If she's your secretary, she must be really good looking. Okay, I forgive you.
But he's still not getting help for it. So I don't know. I'm worried about his fatigue. I'm worried about his nutrition, and I'm worried about his weight loss.
I remember you when you were 14, 15. You were different looking. And I'm on the ball. And I said to myself, boy, that's one handsome, stunning.
What am I now, chopped liver?
And no one knows you that way because they see you now, but I know now that your son is still very handsome, but not like you. You stood apart from everybody.
Some people abuse it, but by and large, most people don't. Most people are really respectful and appreciative that they have that ability.
don't need it. Are you okay? Yep. Sure?
One of our patients today who's undergoing a PET CT scan. PET CT imaging is a modality that we use to detect cancer and to stage cancer. It's a non-invasive test, very similar to a CT scan. The only difference is that we use an isotope instead of a contrast injection, and we're able to get physiologic images which show the activity or the presence of a tumor, and we're also able to get anatomic images.
Don't worry about this. Don't worry about it. Don't worry, I'm dancing. Yeah, I left it with my wife, I'd never see it.
What the machine does is it fuses the anatomic images with the physiologic images. I, as the radiologist, am able to detect not only the presence of tumor, but also the exact anatomic location of tumor and also the activity of the tumor.
Okay, just put your hands right at your side for me, all right? Just like this. I'm going to raise you up and put it inside the camera.
The images that we are obtained by our technologist occur in different planes and different anatomic locations. So this is what we call a coronal image. This is what we call a sagittal image. Another coronal image, which shows the initial activity of the isotope being distributed throughout the body. And we're also able to rotate the imaging in different planes so we can get different perspectives which enable us to exactly locate where the tumor is. The entire examination takes about a half hour. Some patients want to be reassured immediately, and we're very sensitive in being able to give them a quick overview of what we're finding, but I always preface it by letting them know that a more thorough review will be done by me, because I do need approximately a half hour to do a good job for the patient.
She usually loses the car, so we might be walking around a lot.
I don't usually park close.
We're walking home. Could have waited for the bus. I've been on bread and water, no bread. I've been on water for the past day.
He wasn't allowed any carbs at all.
R&R, get something to eat.
Water in the lobby.
No, stop it.
Yeah, they had this. There was water coming through.
It didn't even rain so hard, did it?
Yeah, the 7 inches in the house.
But was it not less than last week? I thought it was.
No, this was worse.
This was
I
worse
didn't
last
call
week?
the last thing a hurricane. I called what happened was a candy cane. This was much
Really?
more destructive.
Yeah, I hear that the subway is flooded.
Subway was flooded.
All right, Ron, you ready to roll? You are, huh? You prepared for this?
Yes, I am.
Okay. So let me walk you through the procedure one more time. As you know, the problem that you have is something called HOCM, or hypertrophic obstructive cardiomyopathy, which is a condition where the blood has difficulty kind of exiting the heart. There's kind of a little block, if you will, just by the exit, so the door doesn't fully open. And when that happens, the pressure in the heart goes up. That translates back into the lungs, and when the pressure is elevated in the lungs, you get short of breath with relatively minor activities.
Having a hard time breathing.
You know, there is 2 ways of treating this. The first is, I think, what your doctor suggested, which basically is open heart surgery. So ideally, we would like to avoid that. The second option is what we're doing today, and that's a so-called alcohol septal ablation, and it's similar to the surgery in a way that the idea is to inject alcohol into that area and shrink that bulge of muscle and basically shrink that whole area down so that, again, the passageway is opened up and the blood is flowing out.
I mean, you should know, though, that people start feeling better right away. 80% of people find they have a dramatic change, and it's what's called a virtuous cycle. As the pressure gets lower in the heart gets even thinner, which in your case is a good thing, because then the pressure in the heart goes further down and your breathing is better and your symptoms improve. So over months it gets better and better. Well, I've only been doing this procedure for 25 years, so we're getting it down.
You know, he has the hang by now. It took 24 years for him to really get there, but I think now last year or so he got better.
Yeah, but we have a huge, as a community, a cardiology community, we have a huge experience with this. And we know, frankly, in someone like you, the outcomes, the longevity, the symptom benefit is pretty much equal to surgery.
Yeah.
Okay?
Thank you very much.
Very good.
All right, we'll see you in a bit.
We'll see you in a few
In the
minutes.
outcome.
I'll recognize you from your mask.
It wasn't a typical delivery process. I went to med school to become a cardiologist. This is what I always wanted to do. And in med school, you have to do all these different rotations. One of those, which I thought I had no interest in, was OB/GYN. I ended up delivering 28 babies during that rotation. And the last day, I remember saying, I'd love the opportunity to deliver my own baby. The way I pictured it was in a hospital with an OB and them just letting me, ceremonially, assist. And it didn't work out at all that way, but I think couldn't have worked out any better. My wife had both an OB and a midwife, and she was exploring the idea of a home birth as well as a hospital. And 2 weeks ago, she woke me up at 2:30 in the morning and said that she's having different sort of pains, but felt that it was just a stomach ache. She goes back to bed. About an hour later, goes to the bathroom and says, I think my water may have broken. I'm like, what do you mean you think it may have broken? She's like, I don't know, a little bit of fluid. I'm not sure if that's what it is. Again, I said, you'll know if the water broke 4:30, 5 o'clock. And now she feels that the contractions are definitely getting more severe. At that point, she feels she needs to go to the bathroom, goes into the bathroom, and she's on the toilet when she starts to feel that she's having real contractions. And this was completely different than what she had been experiencing the previous few hours. She starts telling me, wait, this doesn't feel right. I feel like I feel the baby's head. There's no way, you haven't had any contractions. This is probably the baby's descending and you're just feeling the pressure. And it was, no, this doesn't feel right. I feel like I feel the baby's head. And she asked me to look. So I go to examine her, and while I'm examining her, her water breaks. And it was not subtle, and it was clear that before wasn't the water breaking. And now, it's all over me, essentially. There was no time to think. I remember we both kind of went into this panic of call 911, and our midwife said, you don't have time for that. The most memorable part is when it was that probably 4 seconds of when I saw her head and she wasn't breathing, and it was this panic. I went into a panic, but I knew that if my wife realized what was going on, she was on the verge of a panic attack as it was, so I needed to keep her calm. And it just was the greatest thing when that first cry was the most amazing thing. After we delivered her, that's when I had time to actually start to absorb what we just did. And her placenta started coming out. Anytime you have such a rapid labor, the placenta usually delivers pretty immediately after. So I have the placenta in one hand. I'm afraid she's still kind of in shock, and I'm afraid I don't want her to pass out, so we never moved from the toilet position, and we're holding the baby between us. I did not picture that I was going to deliver my own baby by myself in our bathroom at home. I never realized how much that OB rotation that I did back in med school about 15 years ago would pay off.
It's at 6. That's a 6, isn't it? Room 6.
Oh, I'm sorry.
Which room?
They're in room 3.
It can't be 3.
2.
2, okay. I knew from the second I was going to medical school, I wasn't going to do anything else but pediatrics. And then it's this place. I walked into here in 1990 as an intern, as part of a rotation. And I met the guy that started this practice. And I said, this is why I'm coming. Okay, let's go give this young lady some great news. Pictures. You guys want to come into the office and we can talk for a little bit? I feel like with kids, you can make a difference. My running joke is, if I tell a mother that kid can't do something, he's not going to do it. But, the adult guys, the Richie or, one of the guys will say, hey, listen, you got to give up smoking and you got to watch your diet. The guy will roll out of this place, take a left on Northern Boulevard and he'll be at the Landmark Diner having a bacon and egg and a roll, with the home fries, and on the way in he's going to stop and light up a dart. So I felt with kids you could really make an impact.
So that wasn't too bad at doctors, is it, right?
Everybody says, why do one of the advantages of pediatrics is history of past medical history is that much. Then I look at Richie and Mesafante and Pappas and these guys, Petrosian, and it's just like thousands and thousands of things, 45 medications. I'm like, oh my God. I feel like I'm reading an eye chart looking at half of these things because I don't even know what half the medications they use are, whereas, with us it's, vitamins, amoxicillin, it's easy stuff,
Basically, Sophie, I don't know how to tell you this, but you're really boring. You're really boring because you're really perfect. And as much as we love you and we love your beautiful rainbow clothes, you need to come back.
You're perfect. You're all good.
Yeah, your job is to go have fun, enjoy your life, have a great rest of the summer. Enjoy kindergarten. Say hi to your brother.
Regular heart murmur?
Yeah, this is what we call an innocent or functional murmur. There's no evidence of any residual VSD. Everything is good. Enjoy. And here's my last bit of advice. Please grow up slow. Slow. Because we don't want you growing up fast because you're really cute and we want to enjoy having mom to enjoy having little kids around.
Dun, dun, dun.
Take it from
much more fun to be little, right?
Oh, I take it from someone who's about to be an empty nester. I am not happy. Stay well, okay? I'll have a letter out to the pediatrician right away.
Okay. I've had it on a lot of ends where I've been to a few weddings of patients, and I've been able to watch some of my patients move on into their careers and lives. And then there's a handful of the adult patients that don't want to leave, and they come in and they say, "Can I still come here?" And I'm like, "Oh, you're 32 pushing a stroller. You might want to find, you might want to go see Shlofmitz across the way,
Yeah, and he'll explain to you, but we'll look at your pictures and we'll get you going. Ava was my patient, and now she wants to go to be a doctor.
Yep.
You're just trying to make a difference, One of my closest friends is Pat LaFontaine, and Pat has a saying, individual achievements are great, but at the end of the day, you'll be remembered the most for what you gave back. I kind of live by that saying, but at the end of it all, your mark is what you give back. And just trying to help people find their way, help kids heal up, help some young people figure out what they want to do with their lives or answer a calling.
Okay, Dr. Petrosian.
I just wanted to give you the results and kind of put it in a context, okay?
Okay.
You saw on my chart that the lung lesion is FDG avid, as you said.
Yes.
What that means is that it's suspicious that it is a tumor. It's not a tissue diagnosis. So you mentioned things like small cell, non-small cell.
Yes, that's the only thing that I knew about lung cancer.
So we don't know what this is.
Correct.
What we do know is that it's something that needs further evaluation and then a plan in terms of what needs to be done after that. There's a small area you may have seen on the report in a lymph node that was avid as well.
Yes.
In the hilum. So that could be nonspecific. It could be that something has spread to that locale. Again, that's not clear. And then there was not anything that was avid in the brain, but there was an area in the brain that was somewhat lucent, and they recommended an MRI for follow-up. I don't think that's related to this, but that's something that in follow-up that we would do as well. But again, I don't believe that that's related to this process.
Okay.
I think from a practical standpoint, I think what we ought to do is go ahead with the TAVR, and then after the TAVR, further testing, tissue diagnosis, and then come up with a treatment plan based on that.
Correct.
Okay? I would expect that after the TAVR that your husband would spend 2 nights in the hospital, not 1. And the reason for that is that he has a conduction abnormality on his EKG called a right bundle branch block.
Okay.
So that just increases the risk that he might need a permanent pacemaker. So we typically keep patients like that an extra night.
I mean, he won't be happy to hear it,
But it's minor in the big scheme of things. Okay?
Yeah, considering everything else we're facing,
Right.
one extra night into the hospital is not a big deal. Okay, so we will talk to you soon.
Okay. All right.
Okay, thank you for calling.
All right, be well.
Okay, bye-bye.
Giving patients and their families upsetting news is difficult. It's a little bit impersonal over the phone, but sometimes it has to be done that way. She already knew that there was something that wasn't right, and I had the ability to try to explain it and put it in context.
That was awful. I mean, the waiting is the worst of all. Like now, we know what it is. We know what we're dealing with. Once we see the doctor and once we know we're doing A, B, C, or D, it doesn't become easier, but you're doing something. You're being proactive. You're fighting this disease as opposed to just waiting to see what happens. Just like I said with myself, I know I'm cancer-free and I know I will always be cancer-free, but just there's something there in the back of your head. And we're going to get over it, but it's always going to be there every time he goes for a chest x-ray.
I mean, the retrograde limb of this looks good to me.
It's fine.
So the problem really is antegrade, which is basically subtotally occluded. So my hope was we can just open that and then use the drug-coated balloon in that area. So
That's what this is all about. It's all about relieving symptoms and getting the quality of life up to a level that they find is appropriate.
especially in Ron, I mean, he is very, very symptomatic. He came to me, as a second opinion, and he had this procedure elsewhere, and they recommended the surgical myectomy for him. And obviously, he wasn't so happy about that, and he came to see me in the office. And I mean, his symptoms are very dramatic. He really has significant impairment of his lifestyle. He can't really walk, a block or two or a flight of stairs without stopping because he's short of breath.
And usually people come to our attention a little earlier, whether it's the surgical end or the interventional end. But I'm not sure, this disease is still a little confusing for certain doctors, considered, quote, exotic, though it's one of the most common genetically inherited heart diseases around. Probably 1 in 500 to 1 in 1,000 people have this disease.
So in this particular patient, basically long-term or even short-term, the outcome should be as good as if he had surgery.
I mean, we have this superb imaging with the echo. We could not really have done it without it.
That's key.
You can't just work on one modality. These are complex issues.
Right.
And I think they were invaluable and really helped make this as successful and frankly as straightforward as it is.
Yeah, it was pretty straightforward. I mean, honestly, the team we have here at St. Francis is pretty amazing, and we do this complex procedure now for a long, long time. So we have anesthesia, the nursing, imaging, as you say, all of us kind of working together, and it's pretty smooth. I mean, the biggest difference, honestly, I think, is that if he had surgery now, I mean, the recovery from open heart surgery obviously is much, much more difficult than a more straightforward procedure. He's going to be up in a couple hours. He's going to be out of bed tomorrow and then going home the day after. That would never happen with open heart surgery. So I think that's a big difference.
Right. Always opt on doing less aggressive than more aggressive.
So he did great. What we did was exactly as we discussed. Okay. So we were actually able to find a little feeder vessel, into that muscle area, into the bulge, if you will. Okay. And we were testing it with contrast. It went into the right direction. We had actually a full hit, a bullseye, if you will, which was amazing. Okay. And then we injected a total of 2 cc's of pure alcohol. Okay. And that basically took it out. Okay. So more or less, I think we basically completely ablated it. He did well. So far, he's still kind of waking up. And we're going to move him into the intensive care unit, and we're going to watch him closely. Okay. But so far, so good.
Very good.
Okay? Very good.
Everybody genuinely cares about each other. There's never been a moment where I've felt that if something were to happen, that I wouldn't have the support of every single person here. When things are not going well and somebody's basically, dying, and you just you have this bond that is inexplicable. About a year and a half ago, my dad had called me to say that my mother had just come back from the movies and she was with some friends and she was getting out of the car and she stumbled a little bit and then she was slurring her words, and he called me and he said, "What do I do?" And I said, "Well, bring her here," because in my mind I'm thinking she's having some sort of neurological event. And he dropped her off outside the emergency room, and we do neurointerventions. So the neurologist already, they'd got a table ready, they started to kind of set the wheels in motion that if she needed immediate help, they would do that. The neurologist actually came down to the emergency room with me to just kind of, get the ball rolling. And my dad left her at the doorway. I met her there, she walked in, and she just kept saying, my mother was very she hated bothering me at work. It was like, almost to the point of where you're like, "You're not bothering, Mom, I'm your daughter, you're not bothering me, it's okay." And immediately I was like, well, something's not right here. So we brought her into triage, and as I was talking to the neurologist, I was looking over and I realized she was just deteriorating right in front of me. So he recognized it too, and he called we call it a neuro RT, where they just absolutely bring everybody down for neurointervention. Took her immediately to CAT scan, but at that point, she became unresponsive. From the emergency room right to CAT scan, within a minute or two, she became unresponsive. I couldn't read a CAT scan to save my life of the brain, and even I knew it was terrible. I looked at it and I was like, "Is that blood?" And they said, "Yeah." So she just had a massive intracerebral hemorrhage, and there was just nothing you could do. And you could tell Rich actually came down too. So it was the neurologist, it was Rich, it was the staff, and they all just saw this picture of her with this massive bleed, and they just knew there was nothing any of us could do. And, it was horrific. There's no other word, because I realized this was it. She was dying in front of me. And, I had to now go out and tell my dad and my sister, who were in the waiting room, my poor father. They'd been married 52 years, and he literally left her in the emergency room, went to park the car, we wheel her into CAT scan, he never really got to say goodbye or anything to her. She literally, from the moment she hit the door till when they pronounced her, was 2 hours and 10 minutes. I spent my whole life taking care of other people and fixing them, and I couldn't help her. I couldn't help her at all. There was nothing I could do. So it was difficult. I think it was a hard thing to process. But I couldn't have asked for a better experience. She didn't know what happened. She never felt a thing. She came in. I was the last person to talk to her, which was good and bad. I feel bad, sorry. I feel bad that my dad didn't get to. But I was really the whole time. I got to hold her hand. I got to say goodbye. And I knew she was safe. And it was wonderful being here because my whole family, my work family, was also here. And they were so supportive and so great, and it was a wonderful experience. As counterintuitive as that sounds, it was nice. It was good. Sorry. So. Oh, I don't cry at work. I don't.
You gotta give all you got, gotta give all you got for love. 'Cause you're here for a moment. You give all you got.
You didn't have the capability because it was something that was beyond your control. There's sometimes a higher power, and we have to give it over and realize that it's not something that we can fix necessarily, but you want it because we're fixers and we're healers, and that's what we do. And when you can't, it's hard reconciling that.
You gotta give all you got, gotta give all you got.
In medicine, you never know what the beginning and the end are going to be.
Surgery are you having done?
Toenails. My heart.
Your heart. A little bit of a bumpy recovery.
This is Grandpa's office. You recognize your cousins up? Yeah.
Now we're pacing at 180 beats per minute. Pacing at 180. We're going to drop our blood pressure.
This is Catholic health, right? We sell hope.
No matter the risk or the road you take, the journey is worth every friend you make. When you give all you got for love, you gotta give all you got, gotta give all you got for love. 'Cause you're here for a moment. You give all you got, gotta give all you got for love. 'Cause you're here for a moment. You give all you got, gotta give all you got for love. here for